Good afternoon, everyone. Thank you for joining us for the Future of Nursing 2020-2030 webinar series. I am Sue Hassmiller, Senior Scholar in Residence and Advisor to the President of the National Academy of Medicine on Nursing. The Future of Nursing 2020-2030 Charting a Path to Achieve Health Equity report released in early May and builds on progress nurses have made over the decade. The vision of the report is the achievement of health equity in the United States built on a strengthened nursing capacity and expertise. By leveraging these attributes, nursing will help to create and contribute comprehensively to an equitable public health and healthcare system that are designed to work for everyone. To achieve health equity, the report also envisions a major role for the nursing profession in engaging in the complex work of aligning public health, healthcare, social services, and public policies to eliminate health disparities and achieve health equity. As the largest and most trusted segment of the healthcare workforce, nurses are well suited to help our country advance health equity. But nurses need more support from the systems that educate, pay, employ, and enable them to do this critical work. Across the board, we need to truly value nurses and the work they do to keep us all healthy and well. Today, we will hear from experts that I'm really excited about on the importance of nursing's role in addressing health equity. Please note, we're so happy about this, offering CEUs through the National League for Nursing. This webinar will count towards 0.1 CEU, 1 contact hour. Relevant information will be provided at the end of the webinar today. And now I am so honored to introduce our first speaker and co-chair of the committee, Dr. David Williams. He is the Florence and Laura Norman Professor of Public Health and Chair of the Department of Social and Behavioral Sciences at Harvard T.H. Chan School of Public Health and Professor of African and African American Studies at Harvard University. Dr. Williams will provide an overview of health inequities and its association with poor health outcomes. Dr. Williams, I turn it over to you.
Thank you so very much for the kind words of introduction. It's truly an honor and privilege to have served on the Future of Nursing Committee as the son of a nurse and the spouse of a nurse practitioner. I have tremendous respect for the contribution that nurses have made to my life and to the lives of so many in our society. I'm going to share my screen so that you can see my slides, and we can cover this important topic of the role of social factors and how they, in fact, create inequities in health. To put the social factors into context, I want to begin with COVID-19. And what I'm showing here are the age-adjusted odds ratios of deaths for COVID-19 through March 2 of 2021. And you can see the indigenous population have an overall death rate that's 3.3 times higher than that of the white population, Latinos 2.4 times higher, African Americans twice as high, Pacific Islanders 2.6 times higher. So across the board, you see the populations of color, many of the populations of color having higher rates of death. I think that has to be balanced. It's important to keep in mind that the rate of death is not the same as the number of persons who have died. So if we look at the first 520,000 deaths in the United States, the overwhelming majority, almost 300,000, have been of whites, and 89,000 of Latinos and 73,000 of African Americans, for example. So we are talking about health challenges that challenge all of us, but that have disproportionate adverse negative impact on some populations. These challenges with health equity begin early in life, and despite progress over time, they are strikingly persistent. To illustrate that, I'm going to show you data for blacks and whites of life expectancy from 1950 to 2018. And you could see there was about an 8-year gap in life expectancy. Whites lived about 8 years longer than African Americans in 1950, and it's about a 4-year gap in 2018. So we want to celebrate progress. The gap has narrowed. At the same time, it has taken a long time to get there. So if we look at the life expectancy of whites in 1950, 69.1 life expectancy at birth, how long did it take for African Americans to catch up to the health that whites had in 1950? It wasn't until 1990 that African Americans had the same life expectancy that whites had in 1950. And to put these numbers, these elevated rates of death and the life expectancy gap into concrete numbers that you can have a real feel of what we're talking about. If we eliminated just the black-white disparity in health in the United States, we would save 220 lives of African Americans every single day. That is, the racial disparities in health cost the lives of 200 black people each and every single day. Imagine a fully loaded jumbo jet with 220 passengers and crew crashing today, and the same thing happen tomorrow, and every day next week, and every day next month, and every day for a year. That's what we're talking about, just looking at the African American population when we say there are racial disparities in health. There's a massive loss of life on a grand scale. How do we make sense of these racial inequities? Well, there are large inequities in health by socioeconomic status. And when I say socioeconomic status, I'm talking about income, education, occupational status, and wealth. Here is one example. National data for the United States by household income. These are the odds ratios of death. And you can see that low-income Americans are 3 times more likely to die or have a death rate that is 3 times larger than that of high-income Americans. And every higher level of income is associated with a lower risk of death. So that's a clue as to why there are racial differences in health, because there are large racial differences in socioeconomic status. Let's look at national data on income. Household income in 2018, and I've just translated it in a way that you can't miss the point. For every dollar of wealth that white households have, Asian households have $1.23. Asian households are more likely to be multi-generational. They're more likely to have multiple persons contributing to household income. But if we look at the historically disadvantaged groups, for every dollar of wealth white households have, Hispanic households have 73 cents, and African American and Native American households have 59 cents. Do you know what is stunning about the black-white gap of 59 cents in 2018? That is identical to the racial gap in income in 1978. You heard me correct. In 1978, black households earned 59 cents for every dollar that white households earned. And in 2018, the gap is exactly the same. Most of my students think we've made more progress than that. And these large racial gaps in income markedly understate the racial gap in socioeconomic status. What do I mean by that? Well, income only captures the flow of resources into the household. It tells us nothing about the economic reserves that households have to cushion shortfalls of income. We get that from data on wealth, which is your home equity, your savings and investments. For every dollar of wealth that white households have, according to the Federal Reserve Board, black households have 10 pennies and Latino households have 12 pennies. What does this mean? When a household is low in economic status, even though we are all in the same storm, we're all in the same pandemic, when you are low in economic status, we are in different boats, and some boats are better able to weather the storm than others. When my career started, most researchers thought that racial differences in health were simply a function of racial differences in income and education. I want to show you that the data is much more complex than that. Here is national data for the United States. Life expectancy at age 25. At age 25, the average white person will live 5 years longer than the average black person. So there's a 5-year racial gap. But if we look within race, the gap between whites with a college degree and those whites who have not finished college is 6.4 years, bigger than the black-white gap. And the gap between African Americans with a college degree and those who have not finished college is 5.3 years. Again, the gaps within each race bigger than the black-white gap. At the same time, at every level of education and income, race still matters. So white high school dropouts still live 3.1 years longer than black high school dropouts, and the gap widens as education increases. So you have, and remember, this is national data for the United States. The best off African Americans, those with a college degree or more education, have lower life expectancy than whites with a college degree, lower life expectancy than whites with some college education, lower life expectancy than whites who have not finished high school. So what do these data tell us? That there is something about income and education that drives your health regardless of your race, but there's something else about race that matters even after we've taken income and education into account. And so researchers have been asking for the last 25 years, could racism be a missing piece of the puzzle? And when I use the term racism, I'm not talking primarily about individual beliefs and behavior. I'm talking about an organized societal system that devalues and disempowers some groups and differentially allocates opportunities and resources to groups. It's based on an ideology of inferiority. It can lead to negative attitudes and beliefs, prejudice, and stereotypes. It can lead to differential treatment, that is discrimination. And when we think of racism as a system, one of the most powerful effects it has on health is through structural or institutional racism. And I'm going to illustrate that with data on residential segregation, a historic policy of the 19th and 20th century that determined where you could live based on your race. One researcher who wrote a book about it said it's the most successful domestic policy, or one of the most successful of the 20th century in the United States. And you're saying, what's the big deal about segregation? Well, when segregation shows up in a community, valuable resources disappear, like quality schools and safe playgrounds and good jobs and a healthy environment and safe housing and transportation and healthcare. All of these factors, resources that drive health, vary by place in the United States. Let me share with you a few studies to document the power of segregation. William Julius Wilson and Robert Sampson studied the 171 largest cities in the US. They said there's not even one city where whites live under equal conditions to those of blacks because of segregation, and the worst urban context in which whites reside is considerably better than the average context of black communities. Another study, Professor Dolores Acevedo Garcia, she developed what she called a neighborhood opportunity index, ranking every county in the United States by some 29 different indicators of opportunities for children. Quality of schools, of early childhood education, home ownership rates, access to good environmental quality, access to resources for health. And what did she find? If you look at the 100 largest metropolitan areas in the United States, 2 out of 3 black children, 58% of Latino kids, and 53% of Native American kids live in very low or low opportunity neighborhoods compared to 1 in 5 white or Asian kids. And again, almost 2/3 of all white and Asian kids live in high opportunity neighborhoods compared to 1 in 5 black and Latino kids. Not only that, research is telling us that segregation is the central driver of the large racial differences in socioeconomic status. Here's a study done by David Cutler, national data for blacks and whites. He shows statistically, if you could eliminate residential segregation, you would completely erase black-white differences in income, in education, and in unemployment, and reduce black-white differences in single motherhood by 2/3. All of these striking differences are linked to opportunity at the neighborhood level. So what we are talking about is the way in which segregation, structural racism has created inequities on a large scale. These inequities do not reflect a broken system, but a carefully crafted system functioning as planned, successfully implementing social policies, many of which are rooted in racism. So I've talked about structural racism. There's individual discrimination that leads to stress that also adversely impacts health. And there's discrimination in our culture and stigma and implicit biases that leads to differential treatment in many domains of life, including medical care. This is a report from the National Academy of Medicine back in 2003, documenting racial bias in healthcare. And I want to give you one example before I close. Here is a study published last year of 1.8 million hospital births in the state of Florida between 1992 and 2015. When cared for by white doctors, black babies are 3 times more likely to die as newborns in the hospital compared to their white counterparts. That disparity is cut in half when black babies are cared for by a black doctor. So what I'm saying is there are multiple mechanisms by which racism leads to inequities and socioeconomic status leads to inequities in the United States. I leave you with the words of Martin Luther King. True compassion is more than flinging a coin to a beggar. It understands that an edifice which produces beggars needs restructuring. The health inequities in our society are produced by powerful edifices, and together the nursing profession can take the lead, working with others within our society to restructure all of these inequities. Thank you so very much for your time and attention.
Wow, that was amazing, Dr. Williams. I not only appreciate you co-chairing this committee, but your data are so compelling, amazing. I can't wait to get to some of the questions. So thank you. Next, Dr. Kenya Beard, Associate Professor for Social Mission and Academic Excellence at Chamberlain University, will provide remarks focused on dismantling structural racism in the nursing profession and the lessons learned from the field. Dr. Beard?
Thank you. Good afternoon, everyone. I am honored to be here today. 2 years ago, I was asked by Dr. Hassmiller to discuss racism in nursing at the Seattle Town Hall event. And I remember thinking that nursing was not ready to have a candid conversation about racism and feeling very apprehensive about delivering the talk. Well, I'm back again, and what a difference 2 years can have on thoughts and practices. It seems like every organization is talking not just about race, but racism as well. Earlier this year, the American Association of Colleges of Nursing published their Essentials document, which in its 88 pages mentions racism over 30 times. The document amplifies that nursing education has to be made more equitable and inclusive, and that we must actively combat structural racism, discrimination, systemic inequity, exclusion, and bias. Now, prior to the Essentials, the National League for Nursing emphasized in their diversity and inclusivity toolkit that achieving diversity and inclusivity would take tremendous effort and a candid examination and assessment of decades of practice and traditions that favored some and excluded others. And now the NLN has created the Taking Aim initiative, which addresses structural racism and raises awareness of societal inequities that impact nursing education and healthcare. So I'd like to briefly discuss 2 questions. First, in response to the Essentials, how do we combat what we cannot always see or articulate? And secondly, regarding the diversity toolkit, what are those practices and traditions that favored some and excluded others? Consider this scenario. During a faculty meeting, a colleague discusses the nursing program's attrition rate and highlights that students who were Black or Hispanic were less likely to progress to graduation and experienced higher failure rates on the NCLEX-RN. The faculty members declare that the requests to implement holistic admissions should be immediately halted. Who is more likely to fail out of nursing school? Hopefully you're thinking students who don't know how to study effectively, students who are unable to grasp and apply the content, students who are in classrooms where the teacher is unable to connect teaching and learning with assessments. Notice I didn't say anything about race. So why are we stratifying attrition and NCLEX pass rates based on race? What are the subliminal messages that are reified when we use race as a proxy? And is stratifying based on race, could that be considered an act of racism? Before we dive into whether the scenario does or does not depict racism, it's important that we understand just how racism, defined by Dr. Martin Luther King Jr. as the false doctrine of the congenital inferiority and worthlessness of a people, and how racism is rooted in these assumptions and plays out across systems. These systems include education, housing, employment, health, and the criminal justice system. And they appear to be siloed, but like Dr. Williams shared, they are linked together. Dr. Bassett, the past commissioner for New York City's health department, defined structural racism as the totality of ways in which societies foster racial discrimination. And we do this through using these mutually reinforcing inequitable systems that in turn reinforce discriminatory beliefs, values, and the distribution of resources, which together affect the risk of adverse health outcomes. So in nursing education, when we think about racism, it's important that we consider how the educational system reinforces inequities. When a minority student applies to nursing school, what are the barriers that limit their acceptance? Did racial steering prevent their parents from moving into a town where the educational resources would provide better opportunities for their child's academic success? Were future employment choices limited because minority students were more likely to be steered away from nursing programs? Were they denied a seat because their 3.2 GPA while working a full-time job was not considered competitive enough? Isabel Wilkerson, in her best-selling book, Caste, poignantly illustrates the invisibility of racism, stating that it goes about its work in silence. That's right, we don't even know that it's happening. So is stratifying attrition based on race an invisible act of racism? Wilkerson goes on to say, the string of a puppet master unseen by those whose subconscious it directs. Well, who exactly is directing these practices? Its instructions and intravenous drip to the mind, cast in the guise of normalcy. And when I ask that question about stratification of NCLEX pass rates and attrition, many faculty see the stratification of pass rates as normal. So Wilkinson says, it's injustice looking just. Atrocities, yes, those high failure rates, the academic achievement gap. Atrocities looking unavoidable to keep the machinery humming. So if racism is invisible, how do we make the invisible visible? Several research articles explored the experiences of faculty of color. And two themes that constantly emerged were unequal standards and the myth of intellectual inferiority. In Hasana's paper, one participant shared that he was the first African-American candidate to apply for a faculty position at that school. And after his interview, he was asked to submit 5 years of teaching evaluations to prove that his evaluations were as high as he reported. After being hired, he later found out that the request for teaching evaluations was never asked of anyone else. Normally, references would suffice. To deconstruct assumptions, we could ask, what were those beliefs about this faculty member's ability to teach, and why were his teaching evaluations requested? In a study that I conducted with Dr. Julian from Rush University, we observed findings similar to Dr. Hasana's study. Many participants felt that their academic credibility was questioned and that they were evaluated as relatively less intelligent based on their skin color. One stated, in quotes, seems that coming from an historically Black college or university, it's assumed that our knowledge base is not as strong as the clinicians coming from the traditional majority Caucasian university, end quote. Another participant shared that her academic credentials were disregarded and her credibility was questioned when African-American faculty members were not allowed to teach graduate students. The faculty member said, although she was a practicing nurse practitioner, non-nurse practitioner white faculty were assigned to teach in the graduate NP program over African-American credentialed faculty. Another study by Iheduru Anderson echoed previous studies, and one participant even shared that racism is not always seen as a problem when it doesn't affect you directly. But now we are all being asked to help dismantle racism. So what can we do? This editorial, Diagnosing and Treating Systemic Racism, amplifies the importance of seeing color and recognizing how historical inequities and the social determinants of health impact care and influence outcomes. We have to have these conversations in the classroom. And does race still matter? The need to facilitate race-related discourse and deconstruct assumptions is amplified. In the earlier scenario on stratifying attrition and pass rates based on race, we can no longer sit by idly while the machinery keeps humming. The root factors that drive the academic achievement gap and the erroneous assumption of intellectual inferiority and worthlessness must be uncovered and uprooted. So rather than ask, is stratifying pass rates based on race and active racism? We must deconstruct assumptions and ask critical questions. What are your beliefs about this group? And how might the outcomes that you report place racism in that shadow of normalcy that Wilkerson describes? Or how does it support the false rhetoric of intellectual inferiority and make injustices appear just? In this editorial, we see the importance of reflecting on conscious and unconscious bias that can blind teaching and learning and preparing students to dismantle racism. And lastly, the Future of Nursing report calls on all of us as a profession to not only reflect the diversity of the population, but also to unite and help break down barriers of structural racism that is prevalent in today's nursing education. So how do we do that? I like to call it #JustMove. The M, use metrics to determine who benefits and who is harmed by policies and practices. Consistently ask how racism could be operating and own up to it. That's how we deconstruct assumptions. Vacate old policies, practices, and norms that perpetuate disparities, and establish new norms that advance educational equity and stop the humming. I want to leave you with this quote by Alice Walker. We will be really misled if we think for 1 second that we can change society without first changing ourselves. The Future of Nursing provides a roadmap to get to a place that Dr. Williams described that will be more equitable, not just in healthcare, but education as well. But we can't do it alone. We need to unite. Thank you.
Thank you, Dr. Beard. Wow, I think that was probably the most compelling explanation of how to dismantle systemic racism, structural racism. Thank you so much. So now, next, Dr. Angela Milan, former Children's Medical Services Nursing Director in the County of Los Angeles Department of Public Health, will discuss the importance of creating a shared agenda for the nursing profession to address social determinants of health and achieve health equity. And for those of you who are paying attention, that was the very first recommendation of the report. Dr. Milan?
Thank you, Sue, and good afternoon, everyone. I'm very honored to have been part of the Future of Nursing Committee, where all this work was discussed, and now we have the full report, and I'm very happy to be part of this distinguished panel. And I'm going to start out with, so how do we create a shared agenda? So the Future of Nursing Committee envisions the nursing profession having a major role in this complex work to eliminate disparities and achieve health equity. The decade ahead will demand a stronger, more diversified workforce that is prepared to promote health and address the system inequities that have fueled wide and persistent health disparities, which you just heard from my colleagues. And that by creating a shared agenda, it will help nurses engage fully in these efforts to achieve health equity. Recommendation number 1 states that in 2021, all national organizations should initiate work to develop a shared agenda for addressing social determinants of health and achieving health equity. So further, we need relevant expertise, and they need to be identified and shared across national organizations like the Tri-Council for Nursing and the Council of Public Health Nursing Organizations with their associated organizations, like the Federal Nursing Service Council, which comprises the national nursing leaders of the Air Force, American Red Cross, the Army, Department of Veterans Affairs, Navy, and Public Health Service. We need them because they are very well versed in emergency preparedness. And we're calling out the National Coalition of Ethnic Nurse Associations because they have expertise in addressing the social determinants of health in their community. But again, we need support from the government, the payers, and healthcare organizations and foundations are still needed to implement this agenda. We need to leverage all work, all groups, all expertise, and we need to work as one. So why do we need a shared agenda? Because to address health equity, we will need efforts to ensure nurses in all nursing schools and workplaces are prepared, supported, and empowered to address the social determinants of health. Nursing organizations will need to work together to identify priorities for education, practice, and policy, and develop mechanisms for leveraging existing nursing expertise and resources. We need efforts within nursing organizations to do the hard work of self-assessment, to assess diversity, equity, and inclusion, and eliminate policies, regulations, and systems that perpetuate structural racism, cultural racism, and discrimination with respect to identity, such as sexual orientation, gender, place, such as rural, inner city, and circumstances, such as disability and depression. In order to accomplish a shared agenda across nursing organizations, we will need to develop mechanisms to leverage the expertise of public health nursing as a resource for broader nursing community, health plans, health system, and policy makers. And we call out public health nurses because they're very familiar with the space, the language of social determinants of health, and skill and knowledge of working together in their communities. We also need relevant nursing organizations in care coordination and care management, such as Case Management Society of America, because they have the expertise, the care coordination and care management principle approaches and evidence that should be used to create new cross-sector models for meeting social needs and addressing the social determinants of health. And we also need to develop mechanisms for prioritizing and sharing continuing education and skill training resources focused on nurses, health, well-being, resiliency, and self-care to ensure a healthy nursing workforce. We also need to go outside of nursing organizations to develop and use communication strategies, including media, social media, to reach the public policymakers on health equity related issues. We need to increase the number and diversity of nurses, as you heard, especially those with expertise in health equity, population health, and social determinants of health, those that are on boards and other leadership positions within and outside of healthcare. So for example, community boards, housing authorities, school boards, technology-related positions, we need all of these experts. And one idea that the committee had was to establish a joint annual award or series of awards, recognizing the measurable and scalable contribution of nurses and their partners to achieving health equity through policy, education, research, and practice. And we envision the priority should be given to interprofessional and multi-sector collaboration. So the National Council of Ethnic Minority Association is a good example that I want to share with you. This is an ethnic minority professional nursing organizations who came together to form one group with a shared agenda. And the mission of this group is to be the unified body advocating for equity and justice in healthcare. Currently, our president is Dr. Deborah Toney, and Dr. Elizabeth Gonzalez and I serve as the vice presidents, and we have board members from each of the organizations part of the board. This is the membership. They represent the diversity of all of our communities, and the member organizations are the Asian American and Pacific Islander Nurses Association, the National Association of Hispanic Nurses, the National Alaska Native American Indian Nurses Association, the National Black Nurses Association, and the Philippine Nurses Association of America. So the presidents of these 5 organizations found that they had mutual concerns and committed to joining forces into a coalition which would enable them to leverage their combined expertise. So this is how they approached it. And SEMA identified strategies: 1, to increase the cadre of ethnic minority nurse researchers; 2, to prepare minority nurses to compete successfully for NIH funding opportunities; 3, to establish a plan to increase health disparity research conducted by these nurses. And this is one successful strategy. The project was called the Nurse Scientist Stimulation Program. This was a $2.4 million grant that was funded for 5 years. And the purpose was to increase ethnic minority enrollment in nursing doctoral programs. And it resulted in 252 mentees and 124 mentors participated with equal representation of all the 5 NCMNA member organizations. So yes, this is an example on a much smaller scale than what we're proposing now. But I wanted to share this with you because these are 5 national organizations that came together to leverage each other's expertise across 5 different cultural groups. And I believe that this work is very relevant still, as we need nurse scientists, PhD prepared nurses, to help us create the new models, the new frameworks, the evidence-based interventions to set our metrics and outcomes for this important work that lies ahead of us. So now let's move forward as a profession with each one's knowledge and skills. This needs to be a collaborative effort in order to chart this path and ensure that we have a unified approach, working together, supporting each other. Thank you.
Thank you, Angie. Really appreciate your comments and your expertise and your work on the committee. So I'm going to ask all of the speakers to come back on camera now. We've had some questions. Thank you, Dr. Williams, Dr. Beard. We have some questions and we'll dispense of the slides at the moment. Okay, or not. So we've had some questions that have come up ahead of time, and I'd like to ask our panelists. Let me start with you, Dr. Williams. How about a question that came through? How strong is the scientific evidence that interpersonal discrimination can really adversely affect health. I know you talked a little bit about that, but maybe you'd like to expand on that.
Yes, thank you so much. That's a great question. The study of interpersonal discrimination affecting health is less than 30 years old, but the science is overwhelming. There are, and what I would want to say, it's both discrimination and big things of being treated unfairly at work or not being hired for a job. Those are big things, but the strongest evidence comes from what are called the day-to-day indignities. I developed a scale called the Everyday Discrimination Scale that captures little things like being treated with less courtesy and respect than others, receiving poorer service than others at restaurants or stores, people acting as if you are not smart, if they're afraid of you, just little indignities. And what we find, just to illustrate with everyday discrimination, the people who score high on everyday discrimination, there's a higher rate of incident breast cancer linked to everyday discrimination, higher rate of incident metabolic syndrome, higher rate of hypertension, higher rate of inflammation, higher rate of atrial fibrillation, higher rate of C-reactive protein, higher rate of obesity, just higher rate of mental health problems, so a broad range of outcomes. Let me put it this way. We now have studies from Australia, New Zealand, South Africa, the United Kingdom, and the United States that finds in all of these countries, when you look at racial differences in health and you adjust for income and education, and there still is an effect of race, that effect is further reduced when you add statistically a measure of discrimination to the model. So we now have empirical evidence that discrimination itself is a source of stress that leads to diseases that contributes to the racial disparities in health that we see across the globe.
Yeah, so that connected to another question I wanted to ask you, Dr. Williams, and we'll see who else wants to answer as well. This came from our audience. Can the speaker address racism as a public health threat? As a public health threat, there's a two-part question. Address racism as a public health threat and how nursing can impact this. Why nursing?
I'll say a few things, and Kenya will just elaborate and repeat some of the things she said that I think goes a long way to answering it. One of the things I did in my talk was I just talked about the experiences of discrimination that affects health and that contributes to health disparities. I talked about structural racism through residential segregation, determining where people live, that leads to inequalities, that leads to all the factors like income and education that drive health so powerfully in the United States and the world. We haven't talked in depth on this, but about how discrimination in our culture leads to stereotypes and implicit biases that leads to how we treat each other, how healthcare providers, including nurses, treats individual patients, that affects the quality of care they receive, affects their survival rates. So there are multiple mechanisms by which racism is leading to inequities and thus is, in fact, contributing to a major public health crisis in this country. Again, there are steps we need to take to dismantle it, but I don't want to steal the thunder of Kenya because she elaborated so well on so many ways in which we can address it, and I hand back over to her.
So let me, before you start, Dr. Beard, I just want to point out that the report really does say that it's going to take a lot of people to achieve health equity in this country, right? It is not just nurses. And also, we really need to work a lot with other sectors, those sectors that represent the social determinants like housing and food insecurity and transportation. Given all of that we are all in this together, why nursing? And I'll ask you and Dr. Milan that.
So why nursing? I'll start with that. For one, we are the most trusted. We are the largest discipline. And we have the ability to address this. There's no reason why we shouldn't. Dr. Williams gave us so much evidence for how how this racism works in the background. I oftentimes share a story with faculty about someone like me who enters into the healthcare arena, and I go to see a provider, and the provider is trying to get my blood pressure and my blood sugar to goal. And this is my third or fourth visit. And regardless of all of the treatments, my blood pressure and my blood sugar are still not to target. So I asked faculty members, what would you say to students? How would you explain this in the classroom? Or would it just be another scenario where we don't contextualize this, we just say it is what it is? We don't share that background and what Dr. Williams was talking about, how the social determinants of health influence this. And then I say to them, think about how this mom lives in an area where there's a lot of poverty and crime, and she has a son who just starts college. She buys her son a very nice car so he can get back and forth to school. But unfortunately, every time he leaves the house, because he's in a nice car and they're not in the greatest neighborhood, she is so afraid that the police are going to pull him over. And this is her lived reality, her lived experience. And that fear that her son is going to be harmed, with all of the media amplifying that fear, she presents at the doctor's office with a blood pressure that's elevated, with a blood sugar that's elevated, because we all know how the cortisol in her body is operating because of fear. And we don't have that conversation. We don't talk about what Dr. Williams alluded to earlier, about the fact that with racism, what we experience and how that impacts a person on an individual level. And when they show up for healthcare, what is our assumption about that individual? Because when I ask students or faculty, why are we having such a hard time getting Miss Smith to goal? The overwhelming response across the country is she's not taking her medication correctly. She doesn't know what her medication is. We need to educate her. It's never what are the social determinants or the influences or those drivers that are creating this condition. And until we get there, until we prepare our students, so when they graduate, they are not making these false assumptions and again, keeping that machinery humming, until we have these frank conversations, it's going to be very difficult to achieve these ideals.
Thank you. So the report talks a lot about bringing the concepts of health equity, disparities and health equity into the curriculum. How do you really do that? How do you do that? It's so crowded. One more thing, the committee found that there are some colleges of nursing that are doing a good job, but they are the exception. So, all of you, how do we get this into the curriculum? And Dr. Williams, not just nursing schools, but all health professions curriculum.
So I think this is such an important question because one of the things the committee's report does, it doesn't ask nurses to do all of this work of improving healthcare equity, improving health equity, and doing it on their own and doing it without being prepared to do it. There's a lot in the report of the kinds of investments that need to be made in terms of enabling nurses to practice to the full extent of their training, in terms of ensuring the well-being of nurses so that they are equipped and they are cared for so that they can provide adequate care for others, in terms of providing the education and training so that nurses understand the importance of the social determinants. So for example, we are dealing with a challenge not only of health care equity, that there are sometimes differentials in care based on being from a rural area, based on being poor, based on being a racial, ethnic, disadvantaged, socially stigmatized person. That's health care equity, but it's also health equity. So it's not only what happens within the care context that matters, but as Dr. Beard was just saying, the whole social determinants of health. And that is something important for addressing health equity, but it's also something important for addressing health in the United States. One of the things we have learned from recent studies, including reports from the National Academy of Medicine, is that the United States spends more money on healthcare than any other country in the world, but we have the worst health among the major industrialized countries. So it's not just more healthcare, or maybe the way to put it is we need to put more health into our healthcare. And by that we mean taking care of the social needs, the social challenges that populations face. Yes, ensuring that everyone gets the optimal healthcare, but going beyond that and seeing what are the challenges they face. Let me put it this way. The World Health Organization asked the question this way: what do we accomplish if all we do is give people good health care and send them back to live in the same conditions that made them sick in the first place? So all the asthma medication in the world will not help a child breathe symptom free if the mom that brings that child to the clinic is reporting their poor housing conditions in the apartment where they live that is causing the asthma, and we give them good medication. That's not going to help the child breathe symptom free. And nurses can't solve all of the problems by themselves, but nurses can play a role in reaching out to others within the healthcare sector or other professionals so that we can comprehensively deal with the challenges our patients face.
Yeah. So great point. So Angie and Kenya, how do we ask nurses to really get out of, move out of their comfort zones and work with others in other sectors? I'm going to ask you to start, Angie.
Yes, and I think that's something that public health nurses already do. So I think that's why we keep saying to bring in the public health nurses so they can educate us and teach us this work that they do, because they do that work very well. They are out in the communities, they know their communities. For example, if you would ask a public health nurse about their community, they would be able to tell you about who lives there, about their ethnicity, their gender, their education, all the things that Dr. Williams just talked about their income levels. But they could also tell you, for example, if the community has clean water, if they have clean air to breathe, or is there issues there, or is there a freeway that's close by the school where children from that community attend, so that increases their chances of getting asthma or an asthma crisis and so forth. So I think that we can all do this work, but we need education, we need more resources, like we just discussed earlier.
So Dr. Beard, I have a question for you. You come from the world of education, and this question came in. As a nurse leader, how can I support my staff in seeing their role in promoting and achieving health equity and not having it seen as one more thing for nurses to do?
Oh, that's a really great question. So I hear that in academia, it's just one more thing to do, but I think it's how you reveal it to people. So Dr. Williams shared with us some pretty compelling evidence about the effects of health inequities. That airplane crash every single day, there's no way in the world anyone could see that and say, there's one more thing that I have to do. I know my nurse colleagues would rush to the table, tell me what we need to do. And it's not a matter of one more thing and we're adding something to the table. We're contextualizing what we already do, right? We've inherited textbooks that set the stage for stereotypes and discriminatory beliefs. It's up to us as faculty to empower our graduates and make sure that they understand how these inequities get perpetuated and what is our role in stopping that. So when we talk about who has the highest rate of asthma, we can't just stop the discourse there. we have to continue. And like Dr. Williams said, bring in Dr. Jack Geiger and talk about how he said it's ludicrous for us to treat a person and send them back to the same conditions that contributed to their illness. We have to get to the root of it and stop allowing this thin veil of racist beliefs to linger in the air and not dismantle it, not address it.
Mhm.
So I think we have the power. I believe that faculty hearing, especially all the evidence that's out there today, I can't see someone saying, this is one more thing. What I've been hearing is, how do I do this? How do I recognize it? You have to tell me how to do this, because we've all been conditioned to teach a certain way. And now we're asking people to do it this way.
Yeah, thanks. I know one of the first things that I really have been grappling with, I was so proud when I graduated from nursing school. My mother was a nurse as well. And so proud of the fact that I was graduating being colorblind, making sure everyone was treated equally. And, I didn't see color, right? But that was wrong. I do understand now very, very well that one of the first things we do need to do is see color. So Angie, anything you would add, Dr. Vaughn, to
Yes.
anything Dr. Beard was saying?
Yes, I agree with Dr. Beard that most nurses, once they're educated on all this information, will believe that this is our duty and our responsibility. But I just wanted to remind everyone that nurses need to be supported and they need to be provided with the resources that they need so that they can do this important work.
Okay, so David, we're doing a lot. I'm going to let you have the last question. We've heard a lot about implicit bias training. Does that really work? And to reduce discrimination in healthcare, does that really work? Answer this question for us.
Implicit bias is something real. I like to tell my students that I think of myself as a prejudiced person. And they look at me with surprise and said, yes, I think of myself because I would like to think of myself as a normal human being. And I say, if you are a normal human being, you're probably prejudiced. Not just racially prejudiced, because it's not just about race. Every culture, every society has in-groups and out-groups. Groups that are viewed positively and groups that are viewed negatively. And what research finds is when we meet someone for whom we have a deeply embedded stereotype in our mind, negative stereotype, we will treat that person differently. And maybe you don't have a racial stereotype, but what are the negative stereotypes you have about fat people, about gay people, about women, about old people? All of these are biases that shape what we do. Implicit bias training is powerful in helping us to identify our biases. But what research indicates, and there's so many meta-analyses and reviews, that simply a 1 hour, 2 hour implicit bias workshop does not reduce prejudice and discrimination. It can raise awareness levels, but we have to do more than that. It has to be part of a larger strategy. You've raised awareness levels, and what are the tools that we can use moving forward? How do we change the culture within our environment? How do we give people exercises that they can practice? I sometimes talk about the divine solution. It's Professor Patricia Devine of the University of Wisconsin-Madison that has developed the implicit bias program that has been the most successful. It's an 8-week program. Not a 2-hour program. People come once a week and they get exercises to take home and practice and so on and do. So yes, it is one step. But don't think because you've had a 2-hour workshop on implicit bias, you are ready and you are free and you can.
All right. Okay. Yes, sir. Oh, yes, sir. I hear you. It is a start, but there are a lot of tools in this toolkit. Exactly. I want to thank all of our presenters. Amazing job, amazing information. As mentioned earlier, we are offering CEUs through the National League for Nursing. This webinar will count toward 0.1 CEU, 1 contact hour. You can complete the quiz and earn your CEUs by going to the link on this slide. And on this slide, the quiz will be available until July 27th, but get it in soon. You will need to use this attendance code verification, 6 629. That is your verification code, 629. Again, thank you to our participants, and for your questions, please register for the next webinar on lifting practice barriers and designing better payment methods. It will be on July 21st from 1 to 2:30 Eastern Time. Thanks, everyone, and thank you again to our panelists. Bye-bye.